Dr. Michael Retsky from USA to deliver his keynote speech, please. Thank you. Hi. We cannot hear you, please. Would you unmute in your settings, please? Still, I'm afraid we cannot hear you. If you could just click on the top right side on the view, and if the option of unmute is shown, please, or any red mic, if you could see, just click that for unmute, please.
Unmute?
Yes.
Am I unmuted?
Yes, now you are audible. Thank you.
Sorry for the delay.
No worries, please. So at the bottom, would you like to share your screen with us? There is green arrowhead with some share screen option at the bottom.
Yes, okay, share screen.
Perfect.
Now I open up this
Thank you.
and slideshow. Start from the beginning. Okay, is that right?
We
Can
are
you see
still
the screen?
unable to see your presentation.
You cannot see this presentation?
Now, unfortunately, we cannot see. If you could just click share screen, please, at the bottom, and then open your presentation on your desktop, please.
Sorry, I can't seem to get to that bottom of the screen. I don't see a bottom of the screen.
If you could just click.
If you just move your mouse arrow over your image, then the bottom line will appear. Maybe you can try that. You need to move and then
nothing's appearing down there. Sorry.
Oh.
If you could just move your cursor on your screen, so it will show up. If you could move them with the mouse, the cursor on your screen. So in the
I hear what you're saying, but it's not working. All I have is my presentation on my screen.
Great. Now we are able to see it. Perfect.
You can. Okay.
Thank you.
Okay.
Yes, perfect.
All right. Thanks. Sorry for the problems. Thanks for inviting me to this conference. I must warn you before we start that what I'm going to be discussing is going to sound wrong because it's not what is usually taught as cancer. We're presenting a revolutionary new view of cancer. So be skeptical, but pay attention. And I would expect questions at the end. A question like, I just don't understand what you're talking about. I'd be happy to go over certain things. Okay, I was at Harvard School of Public Health until last week, and our laboratory was closed down, so I have resigned. I'm now looking for a new place to call home. Okay, this project was funded by NIH and Komen Foundation. What I'm going to be discussing is covered in very much level by two recent papers. I published these papers at the end of 2020. One of them is the major paper, Breast Cancer and the Black Swan. My co-authors, Romano Demichelli from Milan, Bill Reshevsky, a medical oncologist, US, Ted James, a surgeon in Harvard, Rick Rogers, a scientist, Michael Baum, a retired breast surgeon, Jayant Vieta, a breast surgeon, Osaro Erhabor, he is a contact of mine in Nigeria. He is professor of laboratory science. Patrice Forget is an anesthesiologist, and he is in Scotland. Both these papers are available online. I'll go through this first one in the beginning. Okay, I edited a book on this subject that was published by Springer Nature, and I happened to very surprisingly see that it was posted on the front page of the New York Times a few months ago, just after the US election. This was the paper, and that's Michael Retsky and Romano Demicheli. So the topic is perioperative inflammation as a triggering origin of metastases. This project has been going on for a very long time. I can tell you when it started. It started in 1993. I was attending a breast cancer conference in Europe. I forgot what city it was. And out in the hallway, I saw a poster presented by Romano Demicheli of Milan. And this caught my eye because it showed a bimodal relapse pattern. There was an early relapse pattern. Well, I'll go through it in extensive detail, and then I walked into the regular lecture hall, and Michael Baum was speaking about a bimodal relapse pattern in data from UK. Well, the three of us got together afterwards and decided that they were both talking about the same thing. The Milan data are by far superior, and I will spend a lot of time on the Milan data. 1,173 early stage breast cancer patients with long-term follow-up. Just a second, please. And there was a sharp peak in relapse at about 18 months, a minimum at about 4 years. And then it started again with a broad, shallow peak at 60 or 70 months with a long tail extending to over 10 years. This general pattern has now been identified in 21 databases from US, Europe, and Asia. There are more than 21, but I stopped counting at 21. Okay, these are the Milan data presented in relapse hazard. Relapse hazard is the probability of a patient entering a period of time relapse-free and undergoing a relapse in this 3-month window. So if it's a 0.02, that means that 2% of the patients who were disease-free entered that particular window of time and had underwent a relapse. So what you see here is there's a sharp peak in relapses at about 18 months. And then there's a minimum about 48 months. And then there's a shallow peak after that, 60 or 70 months. It goes on to over 10 years. There is this subtle bump here about 100 months. We're not sure what that is. It could be important, there could be noise. Okay, these are the same data, but for premenopausal patients. And the only difference here is that you can see structure in that first peak. Instead of one peak at 18 months, there's a peak at about 10 months and another one at about 30 months. And you still see, excuse me, that later peak and the bump out here at 100 months. These are data from Milan presented in New England Journal. Bonadonna, who was deceased, he was the clinician, and he's been working for 30 years on developing chemotherapy protocols for breast cancer. He was the first one to use multiple drug chemotherapy in breast cancer, and Panuccia Valagusa has been the database manager since this project started. I have a lot of experience with breast cancer databases, and I really trust these data, and much of that is due to the presence of the Panuccia Valagusa. So what you see here is there is a sharp decrease in relapse in the first 5 years, and it seems to reach a plateau. And then it starts up again 6, 7 years. It's not an artifact that corresponds to the double peaks. Excuse me. Okay, Demicheli and I decided to collaborate. I have an unusual background. My education is, I have a PhD in experimental physics, and I made a career change into cancer research in about 1982. My skills are, I know a lot about cancer, and I'm very good with calculating. I'm particularly handy at doing computer simulation of breast cancer data. So the idea was I was going to take the Milan database, the Bonadonna Velagusa database, and use a growth model that Demicheli proposed. Demicheli is an MD, PhD. He did a lot of work studying animal model growth. And he said the simplest growth model he can imagine was that cancer starts off as a single malignant cell, can stay at a dormant state for a variable time, and once it starts to divide, it can get to the size of a 1 millimeter or 1 million cells and stay dormant at that time until angiogenesis occurs, and then it can grow to be a detectable lesion or a lethal lesion. So this model is pretty much accepted now, but in 1997 it was probably not well accepted. So
excuse my interruption.
Yes.
We are moving the slides for you. So could you just say very old school next slide? This would be cool.
Next slide.
Thank you very much.
Next slide, please. You're moving the slides, or should I move the slides? Hello?
Your slides will be moved. Just say so you can do it on your computer parallel, but we move the slides in the presentation for everyone.
Okay, good. Okay, this is the result of that computer simulation. I took the Milan data and Demicheli's growth model and tried to understand what these various peaks were. For example, this peak at 10 months after surgery corresponds to avascular micrometastases that were induced into angiogenesis at or about the time of surgery and showed up as relapses at 10 months. The 30-month peak were single cells that were dormant, they were not dividing, and something happened at the time of surgery to induce them to start dividing, and they underwent angiogenesis stochastically. This peak at 70 months, that's pretty much where you first see the benefit of surgery to reduce metastases relapse. So all these events are not synchronized with surgery, but the ones from 48 months and earlier are synchronized with surgery. Those are iatrogenic. Something about the surgical intervention caused those first peaks. Okay, I'm a physicist, and physics is a quantitative science. Every chance I get, I will report information in quantitative level. You'll see that throughout the entire paper here. Okay, that 10-month peak, avascular micrometastases were induced to vascularize. That's mostly prominent for premenopausal node-positive patients. 20% of premenopausal node-positive patients undergo that relapse mode. It's 5 to 1 node positive to node negative, and 2 to 1 premenopausal compared to postmenopausal. The 30-month peak, previously inactive single cells that were induced into division and then stochastically vascularized. The combination of those first two relapse events are 50 to 80% of all relapses. Now remember, these are patients who were not given any therapy, just surgery only. That late peak after 50 months is more or less the natural history of breast cancer. And the benefit of surgery to reduce metastases first appears at 5 or 6 years. Okay, this is another database from Bernie Fisher. Fisher died at age 100 a year or so ago. He was professor at University of Pittsburgh, a very well-known person in the world of breast cancer. And I saw this figure and I said, this is exactly what I was seeing in the Milan data. let me show you what I mean. These are patients treated only with surgery, and they're grouped by the number of nodes positive. 0 nodes on the top and more than 12 nodes on the bottom. Let's look at the 0 node population. First of all, surgery alone cures 80% of the patients. Of the 20% that relapse, 10% of them relapse in the first 3 years, and then there's a period with few relapses, and then after 60 months, they start to relapse again at a less strong rate, not as fast as the early ones. And so you get 10% of the relapses in the first 10 months, first 36 months, and then after that, the other 10% of the relapses. Now, looking at the more than 12 nodes positive, it's much the same as the 0 node pod in terms of the timing, but the quantity of the event, the magnitude of the event is much stronger. For example, all the patients relapse after surgery for patients with more than 12 nodes. The horrible prognosis, but of the 100% that relapse, 80 or 90 of them relapse in the first 3 years. It's pretty much about the same time as the 0 node population. So the timing here is the same. And then it's a period with few relapses, and then it starts up again. Pretty much the same thing as a 0 node population. So what we're thinking here is that nodes positive is an indication of the probability of a patient undergoing a surgery-induced tumor growth at a very high level, and it shows up in the first 3 years. This would say that 90% of the patients undergo this early relapse for more than 12 nodes, and 10% of the patients with 0 nodes undergo that early relapse. Went backwards there. Okay, I've looked at a lot of cancers, and I can find bimodal relapse patterns in all other cancers. I've looked at a lot of them, and these are either case reports or large databases, pancreatic, melanoma, lung cancer, on and on. I don't think there's any cancer that I have not seen a bimodal relapse pattern if you look carefully. Okay, this effect is so large, it should show up if we look at it from certain clinical observations. And I'm going to describe 4 situations here where it's highly probable that we can explain clinical events by what I just talked about before. First of all, adjuvant chemotherapy works particularly well for premenopausal node-positive patients. It cures about 10–12% in absolute terms of premenopausal node-positive patients, but in the smaller single digits for all other categories. Published a number of papers. One paper was 2004, and co-authors are Bonadonna, who has spent 30 years developing chemotherapy protocols for breast cancer patients, and Judah Folkman, who spent 30 years studying angiogenesis. He's the founder of angiogenesis. I was on Folkman's staff at the time. Valagusa, Retsky, and Ronald Demicheli are there. Second thing is mammography works better for women 50 to 59 than 40 to 49. When they first looked at mammography, they were sure it was an improvement, but they wanted to see what the benefit was. So they did clinical trials. Trials were done in Sweden, US, and UK. And when they looked at women age 50 to 59, there was an early appearing strong 20% survival advantage for patients who had a mammography in age 50 to 59. But when they looked at age 40 to 49, there was an anomaly. In the first number of years, first 4, 5, 6 years of the clinical trial, there were more breast cancer deaths among the intervention group than among the controls. This caused a big confusion. It's been called the Mammography Wars. People didn't believe the data because they were sure that mammography works. They couldn't explain it, and it got very ugly. There have been a lot of papers written on that. At any rate, one thing happened very interesting. I was I was studying this effect of the surgery-induced tumor growth, and I was publishing a paper in 2005, and I happened to be sitting at a Folkman lab meeting, and Folkman had invited a Pulitzer Prize-winning reporter from the Wall Street Journal to sit in his meeting, and by chance, she was sitting next to me. She was a premenopausal woman, a writer from Wall Street Journal, and she asked me what I was doing, and I talked to her. I said, I'm studying the impact of surgery on tumor growth, and that it affects the benefit of mammography for women in the age 40 to 49. Well, she was in that age 40 to 49, and her editor was also a female, age 40 to 49. So they decided they wanted to write up something on what I was publishing. So we organized it. And that paper was published in 2005. I don't know the date. This paper came out in the Wall Street Journal. Harvard issued a press release. And so all those things happened at the same time. Got a lot of attention. One good thing that happened from all the attention, I got a letter to the editor from Isaac Gukas. Isaac died a few years ago from cancer. He was originally from Nigeria. He practiced oncology in Nigeria for about 10 years and then moved to UK. So he was a surgeon at one of the universities in UK. He said, what you're describing could explain what they see in Nigeria. He said in Nigeria, women are, when they find a lump in their breast, they do not go to see a surgeon. They go to an herbalist to get some satisfying, some soothing ointment. Then they go back to their village and die from untreated breast cancer because they know from previous women that the surgery makes things happen faster. The word that Isaac used was the surgery provokes it. That's what the people, the females especially in Nigeria, think. So in general, breast cancer in Nigeria is untreated. People just die from untreated breast cancer. We've spent a lot of time on that. Another thing is that there is a racial disparity in outcome. In the US, African Americans have about a 1.5 excess mortality ratio compared to Caucasian Americans, European Americans. But there's an inversion at age 57. Women diagnosed, African American women diagnosed under age 57 have poorer outcome compared to European Americans, but diagnosed over age 57 have superior outcome. So it's hard to trace this to lack of access to quality medical care. It has to be biological. Published a number of papers on that. I would say one of the best ones would be Dema Kelly, 2007. Another thing is that breast cancer in young women is often called aggressive. And I can understand that. They remove the primary tumor, and within a year, the patients relapse. And this seems to be an aggressive quality to the therapist. But from our perspective, it's clockwork relapse 10 months after surgery. And I happened to find this paper written by Irving Ariel. And I wasn't looking for it, but I happened to run across it, and I was fascinated by it. Irving Ariel looked at treatments of breast cancer in a very long time ago. We started 2,000 years ago discussing what Celsus and Galen, Greek and Roman scientists and surgeons and physicians were doing. And this is their writing. It's been translated several times, so the exact wording might not be perfect, but this is the best I can come up with. Celsus, first there's the cacoethes and carcinoma without ulceration and the fungating ulcer. Cacoethes corresponds to a small, obvious tumor, but that has not penetrated through the skin. It's a small, obvious tumor. None can be removed but the cacoethes. The rest are irritated by every method of cure. The more violent the operation, the more angry they grow. You hear about surgeons talking about cancer being angry. After an excision, it recurs, bringing with it cause of death, whereas at the same time, by using no extirpation, protract lives, notwithstanding the disorder to an extreme old age. Okay, you know, this sounds very much like what I was just showing you before. Remarkably, without the use of infection control or pain control, they're actually able to save patients. Galen, we have often cured this disease in the early stages, but after it has grown to a noticeable size, no one has cured it with surgery. It sounds very much like these surgeons 2,000 years ago knew all about this, what I was talking about, but it somehow got forgotten. The most important finding at this point, my colleagues and I came to the idea was that something happens at or about the time of surgery to cause an early wave of relapses. It accounts for over half of all relapses in breast cancer. And surgery apparently induces angiogenesis of dormant avascular micromets and starts growth from single dormant cancer cells. And this may be a general effect, not just breast cancer, but all cancers. Okay, this is skipping ahead to 2010. A paper was published by Patrice Forget and colleagues. This was from a hospital in Brussels, Belgium. This is a teaching hospital where they have to expose all the residents in anesthesiology to all the drugs used in anesthesiology. So what they did a retrospective study. They took the last 230 consecutive treated patients operated on by one surgeon and given conventional chemotherapy and hormone therapy. And they looked at the outcome of these patients for the first 5 years and grouped them by what drug was given at anesthesia. And one drug was by far superior to all the others, was ketorolac. It was the only NSAID that they were using at that time that was IV available. There are a couple other NSAIDs that are IV available now, but at that time, ketorolac was the only one they had. There was a 5-fold reduction in relapses 9 through 18 in the ketorolac patients. Okay, so this is very interesting. We knew that some intervention at the time of surgery would be needed, but what mechanism could explain the Forget data? And I want to read this one sentence from a paper by Hillebrodner et al. The perioperative window can be considered a perfect storm of immunosuppression and inflammation in the presence of residual or circulating tumor cells. At this point, we decided to take a look at a number of very large subjects and try and find correlation among them. Looked at surgery, of course, surgery is involved, inflammation, to find out that IL-6, a conventional accepted marker for systemic inflammation, shows up in serum for about a week after surgery for breast cancer, colon cancer. Angiogenesis is a factor here. Platelets actively sequester angioactive factors, and they degranulate in the presence of inflammation. So there is a surge of about 10% increase in VEGF. That's the major driver of angiogenesis, and about a 10% drop in the number of platelets. There are circulating tumor cells. It's well known that cancer patients have circulating tumor cells. The immune system is compromised, and cancer dormancy is a well-known effect. So there are a number of possible interactions between those very large subjects. Okay, I'm just going to list a number of these things that seem to be very important. Virchow, 1863, chronic inflammation leads to tumor growth. Dvorak from Harvard, 1986, cancer as wound healing gone awry. Bob Weinberg, 2005, cancer usurps the wound healing process. By the way, I edited a book on this subject, and the book was, the preface was written by Bob Weinberg. He did a very good job on it. Balkwell, if genetic damage is the match that lights the fire of cancer, then inflammation is the fuel that feeds the flames. This is a pretty good simplistic description, but it's not too far from the truth. Krebs and C, well established that patients have circulating tumor cells, and this correlates with prognosis. And it is known that daily aspirin reduces risk of late relapse after 2 years of use. Okay, this was a paper I got involved in. There was a paper submitted for publication by El Sager from Lebanon. He submitted it to Biomed Central Cancer, and I was asked to review this paper. This is a case report of a young gentleman who was diagnosed with inoperable lung cancer. They treated him with radiation and let him go. He was just released, let him live whatever kind of normal life he can have. Prognosis was terrible, but for a while he was doing okay. He was driving his car and hit a bump, and he bumped his head on the head visor of his car. And within a month, a 7-centimeter tumor grew at that spot. So El Sagar said, what could explain the sudden growth after minor trauma? And wondered if it was what Dema Kelly and I had been writing about surgery-induced growth. Well, we have this computer model. We have a quantitative understanding of tumor growth, and this cannot be explained by what we were reporting as surgery-induced growth. This is totally different. And I was walking around the lab in the Folkman lab, asking if anyone had any ideas, and someone said, look at this paper by Martins Green et al. This is Minna Bissell's group. And this was a case of a avian root sarcoma virus in circulation. And the interesting thing was that if they wounded the bird at any place, you would get the tumor would grow there. But they could control this with inflammation. If they prevented inflammation, they could wound the bird and nothing would happen. If they allowed inflammation, this wounding would cause the tumor growth. This is similar to what El Sager was saying, but the size of a virus is 1/100th the size of a cancer cell. It's not a good correlation. Another paper shows that under inflammation, there's tissue damage, and this increases the permeability of adjacent capillaries, 30-fold increase in kilodaltons, Agawa 2013. This is a paper from 100 years ago, Jones and Roux, 1914. This is a quotation. The localization of secondary tumors at points of injury has been so often remarked upon that it's unnecessary to cite specific instances, cause unknown. This was at a time when people walked around with cancer far more often than today. Walter et al., 2011, had 2 patients that had something very similar to that. The blood speed in capillaries is 0.5 millimeter per second compared to 40, 50 centimeters per second in larger arteries. So if you had leaky capillary venules, it would be an efficient way for circulating tumor cells to get trapped in a distant organ. And these are papers marking that IL-6, the systemic inflammation marker, is elevated in serum for about a week after surgery. Metastatic process is inefficient. A cancer cell injected into circulation has a very small probability to result in a growing metastatic site. But inflammation, in the presence of inflammation, because there is not an intact vessel wall, there might be an easier way to have the cancer cell extravasate. This is a paper, it's an important paper. I'll be discussing this at the end. Telekas and Dema Kelly, they looked at patients from Norway, 300 patients, and they analyzed these patients who had delayed reconstruction, median of about 30 months. There were something like 300 patients in this data set. They looked at the relapse rate of those patients with time 0 set to the time of original primary surgery, and they found the standard bimodal relapse pattern that we've seen many times. I'll show you that later. They also set time 0 equal to the time of reconstruction, and they got a much bigger early relapse. The result from that experiment said that it's not just cancer surgery that causes this tumor growth, it's any surgery. Clement, we talked about that. Excuse me. This is chapter 4 in that Springer Nature book by Hiller et al. These were anesthesiologists. After reading this chapter, I would be surprised if surgery did not cause tumor growth. They discussed the development of the human immune system over the 2 million years we've been around as a way of helping our ancestors, our ancient ancestors, survive bites from animals or falling off a tree or whatever. After reading this paper, as I mentioned, I would be surprised if surgery didn't cause tumor growth. And one of the major things that they talked about was the fact that neutrophils are generated in large numbers. Generated after wounding, they generated about numbers of about 10 to the 11th. And they are red blood cells, and they circulate, and they release some DNA from their system that is called the neutrophil extracellular trap. It's like a web, it's like a butterfly net, that these neutrophils are going through the capillaries, dragging this butterfly net that can actually capture circulating cancer cells. And since neutrophils have the ability to extravasate, they escort these circulating cancer cells into the tissue. So this could be a very important way by which our immune system and neutrophils and nets can cause relapses in distant tissues. Okay, there were several animal models studied. One of them was by Krall et al. This was from Bob Weinberg's lab at MIT. It was reviewed in NEJM. You can look up this reference. This was an animal model they developed. They could inject cancer cells into this mouse. And if the immune system was competent, these cancer cells would go into dormant states. If the immune system was not competent, then this would not happen. But when they had dormant cancer cells in these animals, they can operate on one side of the animal and get tumor growth on the other side, and vice versa. MIT issued a press release, got a lot of attention, and they found they were able to control this with an NSAID. So the idea that by using an NSAID at the time of surgery, you could prevent these surgery-induced relapses made a big difference. And a lot of newspapers picked up that story. Another paper was published on another animal model, Panigrahi et al. From Harvard. I know maybe a third of the authors on this paper. This is the first sentence in their paper. Cancer treatment is a double-edged sword. Surgery, chemotherapy, or radiation can induce dormancy, escape, and subsequent metastatic outgrowth as a result of the intervention. So they talked about ways how all these can happen. Surgery and chemotherapy and radiation can they can reduce the tumor size. They can also cause exits of tumors from dormant states. A couple of papers I found recently that were pretty important. Lipitz and Harris, 2016. IL-6, the conventional marker for systemic inflammation, is a prognostic factor for many cancers. Kita in 2011, they were looking at the effect, the relative importance of IL-6 on each day before surgery and after surgery. So they looked at 1 day before surgery, 2 days before surgery, the day before surgery, the day after surgery, and days after that. And they found out that the most important time when IL-6 was a prognostic factor was on postoperative day 1. This is for lung cancer. This is a paper that was published in 2017, and I know in 2019 or 2020, it was one of the most highly cited paper in the Springer group. It got a lot of attention. And they looked at prognostic role of neutrophil to lymphocyte ratio, which is another measure of systemic inflammation in breast cancer. It's a major factor and shows up in maybe 10 different databases breast cancer databases that NLR has about a twofold effect on the risk of relapse and the risk of survival from breast cancer. Nothing else, just a measure of pre-surgical neutrophil to lymphocyte ratio. Okay, if I have 10 more minutes left, I hope I do. I want to go through this other paper. This is another paper that was published and also recently, December of last year. It's online, it's available, freely available. And at this point, I was pretty sure we knew how to prevent the early relapses, but it was puzzling to me, why can't we prevent the late relapses? What are we doing wrong? And I spent years thinking about this, and I ended up with an inspiration, and it was based on this paper I mentioned before, Bilecka Kelly, where they measured the disease-free survival, recurrence post-reconstruction for 300 patients who had mastectomy and delayed reconstruction. The delay was about 3 months median delayed reconstruction. And when they set time zero equal to the time of surgery, that's the blue curve here, they found the bimodal relapse pattern, a small early relapse peak in the first 3 years, and then a strong late relapse. But when they set time zero equal to the time of reconstruction, they also got a bimodal relapse pattern, but it's a much stronger in the first 3 years than afterwards. So as I mentioned, the important thing to them was that this was not just an effect of surgery-induced surgery on cancer, but it's general surgery, because these patients supposedly had no cancer. I was thinking about this, and this is what I came up with. I respect they did the work, and I respect that it's quality done. Kelly did it, and I'm sure it's right. But if they did not analyze these data, if they did not look at these data for the patients who had the relapse, who were the same patients, but if they looked at the ones who had T0 at reconstruction, these patients would have late relapses, ordinary late relapses. Nothing special about them. However, we know that these patients had cancer cells sitting in dormant states, and the surgery caused these early relapses. The early relapses to them were in the first 3 years after the reconstruction, and if they did not analyze these data, these patients would be ordinary late relapses. But we know that these patients would do better if they had been given NSAID perioperative ketorolac at the time of reconstruction. So the conclusion out of this is that any breast cancer patient or survival who is at risk of late relapse could benefit from using NSAID ketorolac when any planned surgery is conducted for a cosmetic or health issue. So these patients had the surgery for a cosmetic issue, reconstruction, but I know a lot of cancer patients who have surgeries within a few years, 5, 10, 15 years after surgery, and they don't know about this. This paper is going to save lives. Conclusions: the early relapses of breast cancer, which comprise the majority of relapses, are surges of angiogenesis and single cell activation triggered by primary surgery and maybe the late relapses. The Forget data, retrospective data, that suggests ketorolac reduces early relapses 5-fold. This still needs to be confirmed, and we predict this can reduce breast cancer mortality by 25 to 50% at low cost and toxicity. The only side effect that's a problem is excessive bleeding by giving an NSAID at surgery. And a friend of mine, an orthopedic surgeon, said that they've been using tranexamic acid for years, and that reduces bleeding after breast cancer surgery by 39%. So that could be a way of reducing the problem with ketorolac. These data suggest that the transient systemic inflammation is what precipitates the early angiogenesis and single cell growth from dormancy. Breast cancer runs its course in over a decade, but most of the events that lead to relapse occur in that first week after surgery. And it looks like the metastatic progression is amplified 100-fold during that post-operative week. Protocol is published for that perioperative NSAID and also a post-operative oral NSAID for 4 days. Second Belgian retrospective study was published in Journal of National Cancer Institute, Desmet Demicheli in 2018. It confirmed what Forget had. So at this time, we say after 2 retrospective studies, extensive analysis of clinical data, and 2 mouse models, the Crale paper and the Penography paper, we think it's time to conduct 1 or more clinical trials, prospective trials with triple-negative breast cancer. We think that category should respond best to perioperative NSAID. The trial's in the planning stage at Beth Israel Deaconess Medical Center. Ted James is the chief of breast surgical oncology there. The cost, this drug costs $5 per patient, and there are 2 million new breast cancer patients per year. So for $10 million in cost, we could cut the breast cancer problem in half. Surgery-induced effects are apparently host responses to surgery with little to do with the cancer cell genotype, and it's not the fault of the surgeons. It's not sloppy surgery by the surgeons. And it seems to be a general effect based on retrospective studies. Perioperative NSAID ketorolac seems to work in ovarian and colon cancer, and it's been references here. And the late relapses seem to be preventable by controlling the perioperative window, and that was published in my paper in Censors. These are my colleagues. Rick Rogers, who was the lab director at Harvard. I was part of his lab. The lab was eliminated in the past few months, and I have resigned from Harvard. This is Pat Wood. She was the wife of Bill Reshevsky. Bill was the medical oncologist I used when I was treated with stage 3C colon cancer. I was the first one to use metronome chemotherapy. Pat Wood died of cancer a year or so ago. This is Romano Demicheli from Milan. Above Romano is Pinucci Valagusa. She's been the database manager in the Milan database. This is Gianna Bonadonna. He passed away a few years ago. He was the clinician in the Milan data. To the right is Patrice Forget. He's the anesthesiologist. He's now in Scotland. This is Vikas Sukhatme. He was at Harvard at the time. He's a dean of medicine at Emory in the US. In the middle picture here, I'm standing on the left, as Romano Demicheli. This is Jayant Vieta, who is a surgeon from UK. This is Isaac Gukas, who, as I mentioned, he died of cancer, but he was a surgeon, breast surgeon. The lower left is Usaro Erhabor. I've been to Nigeria on 3 trips in the past few years, and Osaro is my main contact there. He's one of my very good friends. And this picture in the middle here is Michael Baum, a retired breast surgeon. There is Isaac Gukas and myself. We were having lunch at the Royal Medical Society in London. This is Ted James, the surgeon from Beth Israel Deaconess. And the lower right is Judah Folkman from Harvard. He's dead also. Thanks for your attention. I'll be happy to take any question.
Thank you very much, Dr. Michael Retsky, for this valuable information you have provided in the presentation. So anyone has got any questions, please?
I realize this is very unusual research to you, and I would not doubt that you're very skeptical. So a skeptical question would be perfect to ask here. If there's something you don't understand, it's the perfect time to ask. I've presented this many times, and I'm always getting questions that may sound stupid, but they're really good questions. If you don't understand something, maybe I didn't explain it well enough.
Yes, you are absolutely right. Yes, I do agree. So you mentioned something about interleukin as a prognostic marker for inflammation.
Yeah, the marker is the accepted, well, there's not one accepted way to measure systemic inflammation. Neutrophil to lymphocyte ratio is one good way because you can just look at a complete blood test and just read it off there. Many people have done that. It's a good prognostic factor. And also IL-6 is a good prognostic factor. And the dietitians use another marker, I forget the name of it exactly, but the dietitians also worry about inflammation and they measure inflammation by another marker altogether. But these markers don't all correlate, they're all valid, they're all useful.
All right, thank you. Thank you for informing. Anyone else has got any question, please?
Hey, thanks for your attention.
Thank you, Doctor. So now I'm